All right, we'll go ahead and get started. We do have a few more people that are planning to show. Welcome to September 29th, 2016 Board of Health meeting. For the record, Kevin Freeman is ill today, which gives me the opportunity to serve as your chair for this meeting. If we can go ahead and get started with introductions. Torney, we'll start with you.
Torney Smith, Spokane Regional Health District.
Brian Beggs, City of Spokane, Council Member.
Bob Lutz, appointed citizen.
Ann Pittsnoggle, Recording Secretary.
Michelle Fossum, Legal Counsel.
Lori Kinnear, Spokane City Council.
Chuck Hafner, appointed.
And Shelley O'Quinn, Spokane County Commissioner. All right, so that brings us to item number 3 on our agenda, which is citizen input. I do want to point out for our board members that we had a citizen who was unable to join us today, but provided you with information in your packet. Rich Withers is a concerned citizen and wanted to provide you a bunch of information on the Zika virus. So that is in your packet. He was unable to come and actually testify. Signed up to provide testimony. John, I am sorry, I cannot read your last name. There you go. Come on up. You have 3 minutes to speak to the board, and you're welcome to join us right there. Thank you very much.
Just actually wanted to find out, actually, if this is the meeting that I really need to be to talk to you guys about the fees that the health department is charging for businesses. On top of your normal fee schedule, how do you guys come up with charging for $130 an hour, or where do you guys get these numbers pulled up from? On top of what you're already normally paying for your fees as a business. But for reviewing an application, businesses are getting charged $130 an hour just to have that reviewed. And me as a business owner just thinks that that's part of their job that they get paid for all regular on their biweekly basis every week, however they get paid, but also to have some business pay them $130 an hour on top of that. Just think it's a bit obscene. So I'm just trying to find out, how do you guys come up with those fees? Because 4 years ago it was $90, and every single year it's just been creeping up, and now we're up to $130. So.
Have you had a chance to sit down with anyone from the health district to discuss the fee schedule?
I did. They told me that if I wanted to talk to somebody about the fees, to come to the Board of Health meeting. And that was the Steve Main, or head honcho guy up there.
So maybe I can connect you with staff and have them walk you through our fee schedule and how we determine our fees. And then if you still have concerns at that point, because they can go in detail how each of them are, how we come up with each of them. I can tell you that we do have the board has a policy for 100% cost recovery on our fees, but that's what our goal is. But I would love to have you sit down with staff to go over that. Yes, Brian.
I just in listening to you, it sounded like that $130. That's not. They don't get paid that on top of their salary. That goes to pay their salary while they're doing it. So I didn't know if that was clear to you. They don't get that money. We're getting essentially reimbursed for the time they spend.
Right. So I guess, how do you guys come up with that amount of money for fees? I mean, no offense, they're not doctors.
Right.
They're not lawyers. I mean,
I'd like to get paid $130 an hour
as well. But
yeah, I'll have you connect with staff, and they can walk you through it. Thank you very much.
Sure.
Anything else you would like to share on that today?
Nope, that's fine. I'll just talk to them.
Great, thanks. Rose?
I like to read shirts. I'd like you to read my shirt. I did have a very sunflower summer. I took 3 grand champions at the fair. And I would have brought the ribbons, but that would look like I was bragging. So I'll admit to the fact that I was bragging. Made this. Let's see. I do like to brag about this because I've been a recycler since I can remember, and this goes all the way back to before the 60s. These pair of mittens are crocheted out of scrap. I hate to throw anything away. For those that don't know me, I'm Rosemary Waldron Larson. I live in Green Acres. I've been attending these meetings since 1997 just to keep track on the chronic push for water fluoridation, which is a failed public health theory. And I know the background because I used to live in Kingston, New York, which was the unfluoridated control in the New York State Health Department's study of fluoridation on the citizens in Newburgh. And I know for a fact that it's a fraud. It's failed. And if anybody wants to get the details, they're quite welcome to ask me. As I said to you last time, one of my disappointments with this august body has been too few people ask questions. You just sit there and take it. Well, except for you, Chuck. You're going to be hearing more from me. I'm going to continue to attend these meetings because, as I've twice now told you over the past 10 years, I intend to live long enough to make all of my enemies regret it. And since the good Lord promises mankind, as long as he behaves himself, nutritionally that is, at least 120 years, I'll leave it at that and exit stage right.
I'd like to make a correction. At one time you told me 16 years, not 10. Now, which one is correct?
Unless I go back into my files and check it, you may have brought me up.
Oh, okay, thank you.
But it has been twice.
All right.
The first time I said was God willing, going to live to be 100.
Okay,
And then I modified it. I retracted
okay, thank you.
Thank you, Rose. And you have beautiful sunflowers. Appreciate you sharing. All right, is there anyone else in the audience who would like to provide citizen input today? All right, seeing no one moving forward. Chair report. So, welcome to our new board member, Mike Munch, with the Spokane Valley. Thank you for being here today, for joining us. If you did not recognize, we do have a new board member. So, Keith Baldwin resigned because he moved to Colorado to be closer to his family, and he left. Actually, he's left town already, so we're going to miss him. We appreciate the time and service that he gave to this organization. He did give us the heads up that he was resigning, and so the county went ahead and posted the position, and Chuck applied for the position, and so the commissioners appointed Chuck to fulfill Keith's term. So thank you for coming back on board. We love having you as a citizen representative. What else do we have here? We do need two people for the Budget and Finance Committee. So I was hoping that we could rope Mike, or who's the other Valley? Pam. So you can either, you can grab it or tell Pam she missed it or she gets it because she didn't show up today. And Chuck, I was hoping we could rope two of you into serving on the Budget and Finance Committee. Okay, that would be great. Thank you very much. And I'll make sure that we get you the times for that. And then other committee updates. Do you want me to do those right now? We'll do that later. Oh, for the next. Oh, okay. So I think that's all for my chair report. We do have Mark, is that correct, who will be joining us to give, for the health officer report, will actually be our epidemiologist for the epidemiologist report. Sorry if I have that wrong, but now it's your turn. Go ahead.
Thank you. So I just have a couple updates coming on what was presented last month with the board on just a few topics. We're still seeing some significant, for us, West Nile activity. This is probably the most number of cases that we've had in people and animals since the outbreak began. So we've had 3 people diagnosed with West Nile who are Spokane County residents, and at this point 7 horses and 1 crow have tested positive as well. So we anticipate probably seeing some activity going into the next couple of weeks or so But we don't understand why this season caught us a little bit with more cases in the state than past years. It's usually driven by climate conditions in terms of allowing the mosquito population to grow and to amplify the virus in birds, and so we are seeing a little bit more activity with that this year. In terms of Zika virus, I'm not aware of what the question with the person who wrote in to the board on that, but we're seeing some additional local transmission in Florida that continues to be a concern. The Congress did finally vote to provide Zika funding. I think it's $1.1 billion to the CDC for combating the outbreak. We are not, at this point, seeing any cases in Spokane. We've submitted, I believe, 26 people for evaluation for Zika at this point. Continues to be a little bit of struggle in Florida, and primarily it's because, the algorithms that CDC has for us in terms of when testing is going to be approved are based on areas of local transmission. And if a new area is identified, then they will backdate that. So there is a possibility that someone could not be eligible for testing, and then if local transmission is identified in that area where they traveled, that they could be eligible for testing 2 weeks later. So that's kind of a limitation in terms of the testing capacity that we have in the U.S. But at this point, we are seeing a handful of people, every month who are requesting testing for Zika. In terms of influenza, we're starting to see vaccination programs starting for flu this year. We have had one hospitalization reported to us in September. We're seeing some flu activity at a very low level with some of our labs, but nothing else in terms of impact on the school system, in terms of absenteeism, or any facility-based outbreaks in terms of long-term care settings. So this is what we would anticipate for a normal flu season. Activity for us tends to be very sporadic until we hit November, December, and then we start seeing a gradual uptick in terms of activity, and we peak generally in January through March in terms of flu activity. And then one quick update in terms of pertussis. We're still seeing continued activity, especially in Central Valley and Freeman school districts. That's where we're seeing cases to date in September. We've had 9 pertussis cases reported in September. Most of those are in people who are unvaccinated and tend to be in elementary age children or in child care. Just those were kind of the updates that we had for this meeting. Are there questions that I can entertain from the board?
Any questions? Yes.
Is the Zika virus, does it use a specific mosquito for host?
It does. It does. So Zika virus is primarily transmitted through the Aedes aegypti mosquito, which, at least in the U.S., tends to kind of affect kind of the southeast, Texas, parts of California. We don't have that mosquito here in Washington State, and so we would not see local transmission occurring here. But it is something that is a concern because there's a number of people who travel to kind of the Southwest in those states. So if we start seeing more local transmission, that's going to impact our healthcare system significantly.
Can it be transmitted person to person as well? Or?
It can be transmitted person to person. It's primarily a mosquito-borne disease, but it can be transmitted sexually, both male to female or male to male or female to male. It is something that's theoretically transmittable through the blood supply, but at this point, our blood supply in the U.S. is being screened for Zika virus.
Great, thank you.
You're welcome.
Any other questions? Okay, thank
Okay,
you very
thank you.
much. Have a great day. That brings us to our legislative report. Linda, oh, nope. That brings us to Torney. We need to add administrator on there. Sorry, Torney, wasn't trying to skip you.
Not a problem at all. Thank you. Good afternoon, everyone. What I want to cover with you today are these items. And to start with, if we can find the keyboard. First of all, recognition of the work that Linda Graham does. She will be doing the legislative update for you. But in addition to educating all of you and working with our local and state representatives, she has been coordinating and communicating with our national policymakers for them to see what happens on the front lines back in communities that they represent. One example is that on August 16th, the Nurse Family Partnership Program visited a family with the nurse Elrika Kaufman, who took Representative McMorris Rogers on this site visit. And it was heartwarming to hear the story back from the clients to our representative, talking about the benefits that they have received from this program specifically, and that in particular, they learned a lot of information from the public health nurse that countered what they heard from other trusted sources that they have in their lives, and basically lamented that more folks in their circumstance weren't also able to have a nurse-family partnership nurse with them. We certainly have a limited capacity there, and the demand far outgrows that. Senator Patty Murray visited our opiate treatment program on August 23rd, and there she was seeing the outcomes of what she is supporting nationally. She met with 2 different clients in the program while they were here for treatment, learned about housing challenges that those people were having. She then had a chance to go through the dispensary. She has never seen how methadone was dispensed, and so she had that opportunity. She was curious about efforts that she has made at a national level to try and provide sufficient funding that all Medicaid clients in need of opiate treatment could receive it, and that just isn't the case. There is not enough money that trickles down from the state through the county to ourselves that gets directed to our agency to cover. So we have a waiting list now of over 100 people. Though our count is in the mid-700s right now, Julie? 780. So we still have this waiting list. She then followed that tour of the facility by doing a press conference with Dr. Matt Layton, who is our medical officer for the opiate treatment program, a professor at WSU. And then she met also with Dr. Darren Nevin, who is a Sacred Heart physician in the ER room and the medical director for Consistent Care Program. These are in your packet. They are articles that you would see that are colored like this, and it is a story that was done in the Washington State Magazine from the university looking at opiate treatment and identifies the work going on here in the health district. At the bottom of the page there, you can see a spokesman review article talking about Suboxone, which is another treatment modality that can be used for an opiate substitution treatment. And there was an article covering sort of that overall Suboxone piece, but did talk about what goes on here in our treatment program. Wanted to also bring to your attention the Medical Reserve Corps that is coordinated out of our DPR division. Between July 1 of 15 and June 30th of 16, they did 73 different activities with volunteers. That was the most active Medical Reserve Corps in the nation. They did a total of 3,079 volunteer hours that were contributed. The economic value of that is $116,000 plus. Want to just update you on our elevators. I had mentioned before that we were nearing being done on the elevator, the public elevator in the front. It was inspected last week, and had a single failure on a light that is supposed to identify for the fire department an earthquake issue related to an elevator declining or falling some area and then stopping. So a part has been ordered for that. We would hope that that will be repaired today or tomorrow, and we would expect that first elevator to be done. So our public elevator should be operational sometime next week. The second elevator, which is the employee one, we continue to believe we will have that completed by the end of the year. It should start its work in rehabilitation in about 2 weeks. Also mentioned last time that we had planned to have a security guard start here with Kodiak Securities, and we have seen amazing improvement in client flow, less congestion in the front area where client services is, where payment and vital records exist. They also have been active in helping support the no smoking rules around, where people used to be walking up the sidewalks and then flipping their butts out on the lawn. That is now getting much more under control. And we have received compliments both from clients and staff on how much smoother things seem to be going. So early on, this has been a very positive piece. I think the other piece from a employee perspective is that people have a higher sense of security just in terms of coming and going from the building. I wanted to talk just a moment about information looking forward from where we are today. If you look right now at people in our agency who are age 65 and older, there are 8. In 5 years, we will have 39. Those who are currently in the agency, 60 plus with 20 years of service, which means they're in retirement age, there are 20 of those. In 5 years, that'll drop to 14 because many of them will go contribute to the 39 above who will be 65 and over. But basically, right now, today, we have 28 people in this agency who are eligible to retire. 5 years from now, that will go to 53. And if you look back over the last 2 years, we have hired 92 new employees. So there's a lot of work to be done in succession planning, thinking about how we maintain the understanding that walks out the door when somebody who's been here for many, many years leaves. How do we transfer that on? Very much on the positive side, folks who are coming in are very much more objective than those that have always done it a given way. There are people who are willing to look and explore on how we can do things better. But this is part of the landscape that we're looking at over the next 5 years. I was asked also to talk just briefly about the drug take-back. There have been efforts nationally to try and find ways to take unused medications out of the home and get those returned into a safe disposal way. The national take-back effort is scheduled for Saturday, October 22nd. And if you look at the very bottom on the right-hand side, the only pharmacy at this point in time identified as participating is the River Point Pharmacy. And it's noted that they do not take back controlled substances. So as we worry about our opiates and so on, this is not going to really resolve the problem. So this is something that I know we have spoken about over the years, and I think that it's something that we, as Spokane, need to continue to try and figure out how do we put things in place that can address that. Oh, yes, Breen.
Question about that, and is that something that the health district can or can't do, the take back?
No, right now it has largely been done through law enforcement. Right. There have been pharmacies that have signed on to be able to do that, in particular with controlled substances.
What about like fire departments?
Not to my knowledge. Julie, no.
But is it, I guess my question is it legal for them to?
No.
Okay.
And I think that's the challenge from a national effort, is trying to figure out who is first willing to do it, and then making certain of those components legal. To this point in time, it has been some law enforcement offices and some pharmacies. And Kim, you could...
Walgreens on Division is accepting it now.
They are now? Okay. So Walgreens on Division, thank you.
Are they accepting the controlled substances? They are?
So
Okay.
have them get their name on the list, because at this point in time,
So I'm curious.
I
though.
pulled this off DEA this morning. And Linda?
Yeah, I just wanted to note that part of the reason there's not a lot of entities doing this, including the health district, is there's just some very stiff requirements around record keeping and storage of the medications and those kinds of things. And so we have to go by the federal regulations.
So I'm just curious, though. Brian brings up a good point. Could either Spokane Police Department or the Sheriff's Office choose to be involved?
And Lindy, did you have input?
Yeah, so statewide, the Washington Poison Control Center, or Poison Control, is working on a take-back program throughout the state. We now have an Eastern Washington rep that's actually housed at the health district. And so they will be working with different potential sites and a website that indicates like where you can go. And so they're really kind of handling it.
Okay.
Good. So my hope would be that we also can get that information back to the DEA site, because that's where many people, if you go and look at Take Back, that's where Google takes you at least. So good to hear that there are other efforts going on. Yes.
Just for the record, could you clarify, is that the Walgreens up at Lincoln or the one on Empire?
Lincoln and Division.
Okay, thanks.
Great. We are, as I mentioned earlier with the security guards here now, we are working to make sure that the health district campus identified in the lower right corner, which includes our building and the surrounding parking lots, will be totally tobacco and vape-free campus. The places that are highlighted in red are on the county campus, that those are designated smoking areas. And so that is what we are referring people who wish to use tobacco or vaping products to go to those areas as opposed to being around our facility. Any questions overall?
Questions for Torney? Great, thank you very much.
Thank you.
All right, so that now brings us to Linda, who will give us our legislative report.
Thank you. So for Mike, I'm Linda Graham. I do the policy analysis work for the agency. And before I start on the legislative report, I do want to note that our policy committee is down to 2 members. So if it's possible to get some more membership on that committee, I think Amber and Kevin might like some company.
Right, so anyone who wants to volunteer for that, just let us know. If not, we can assign you.
Okay, thank you.
And quickly, the duties of the committee are to vet potential policy issues to bring forth to the whole board for consideration and discussion, and also to give some initial feedback and help on the legislative agenda and help support Linda in her work on that. So,
Perhaps Ann can send out a communication requesting people that might wish to apply for that, simply because there's quite a few absent today. Would that help you, Amber?
right. Maybe we could set it out on all the different committees if there's any that are. Sounds like we filled up the budget, maybe, but but maybe we could put how many slots are available, and then just a quick synopsis of the committee duties. That'd be great. Thank you.
And keep in mind, you can be in both policy and budget if you'd like.
We volunteered.
Just thought I'd bring that up.
We volunteered, Mike.
And again, before I get to the legislative agenda, I just wanted to mention some materials that were in your packet this month related to some smoke-free housing and smoke-free worksite policies. We put them in your September packet so you'd have plenty of time to review all that. You will receive a presentation on those, and as well as the guidelines and recommendations that are coming forward to you for your approval in October. You'll have the option to either vote in October or December, but to help you in case you wanted to vote in on that measure in October, we wanted to make sure you had the materials nice and early, so that's why they're there. Just for benefit of Mike and then review for the rest of you, the legislative agenda process, as Amber mentioned, it first goes to the policy committee for some considerations. The way it's developed is I work with a lot of our partners throughout the state, whether that's WSALFO, the Washington State Association of Local Public Health Officials, other LHJs, entities like the Public Health Roundtable, Heart Lung Cancer Associations, those kinds of entities, and put together some ideas of key critical policy and funding things that need to happen in the legislative session. And then I bring them forward first to the policy committee. And then the September meeting here at the Board of Health is your first chance to look at it, ask some questions, let me know how much more information you need on those issues so that I can bring that forward to you in October for further discussion. And then you vote on the final legislative agenda in December and put that in a resolution form. So what you have before you, there's a couple things in your packet. One, I included the outcome of last year's legislative session relative to your agenda. So I noted any bills that passed concerning those issues, and as you'll see, there wasn't a whole lot. And that is why you'll see those issues still on this year's legislative agenda, but you do have the option to pull those off. This is really just an initial list for you to look at. The biggest issue coming forward this year, it's a statewide effort, it's the foundational public health services. We have been working on this for several years as a public health system throughout the state, trying to identify what are those critical public health services that every community should expect to have and that should be funded by the state. And we've been working really hard to try and develop a good communication system of how do we convey this to the legislature. We've been working with legislators, the governor's office, to try and put together a specific funding proposal that will go forward. Most of those materials are coming together right now, getting those finalized. So this is going to be the major push for the system statewide, so hopefully we'll have that on the board's agenda. Did you have a...
Yeah, I just, Commissioner Mielke, Todd, when he was commissioner, served on the state task force for this item, and I know that the devil's in the details, and there was a lot of disagreement, even amongst professionals, on how you define basic health. So before we take a vote on this, are we going to have a chance to review how it's currently defined? Because I know there's been a lot of debate on it.
Right. That was the plan for the next go-round and asking how much more information you needed. But those materials that they're putting together right now in terms of the final set of the foundational services and the funding requests are being put together right now. They should actually come out in the next couple of weeks so we can have them for the October packet.
Okay. I think that's important, is to have as many details on that one specifically. Because if you look at what happened with education, basic education was never fully defined until the legislature defined it in the 90s. And once they defined it is when, that was the basis for the McCleary decision. And not that that was bad, it's just that you have to understand what the long-term potential ramifications are when you define that. And ensure that, and there was such a broad spectrum of debate on this issue over coming out of the committee at the state level, that it would be great to see what they finally came up with.
Yeah, we will definitely bring that forward to you. Another major push statewide is under the policy issues. It's the tobacco and vaping regulation. What they're moving forward with right now is being called Tobacco 21. And the idea is to raise the minimum age to purchase tobacco and vaping products from 18 to 21. Noting that that is the time period, that age gap right there is when most youngsters pick up smoking. There's studies that show that if you haven't started by the age of 21, you're very unlikely to then start smoking. And the way that most young children get the cigarettes is from that age group of particularly 18-year-olds who are still in high school and then able to pass on the cigarettes to the younger kids. So that's going to be a major push this year. It's legislation that's being pushed by the Governor's Office, Department of Health, as well as the Attorney General's Office, and of course Heart, Lung, and Cancer Associations. And one of the things I will be bringing forward, I didn't give it in your packet today, I just wanted to kind of get you the initial list, is a resolution specific to Tobacco 21, or a letter of support from the board as a specific statement of endorsement for that idea. So I'll bring that forward next month. So I don't want to read through all the other items on here. I'm assuming you have been able to review your packet. So I just want to ask, are there any questions about any of these ideas, any input on other issues to add to the list, any things you initially want to take off the list? Or what other information can I bring you in terms of background on the issues?
I think for me, if there's any of these that you have specific legislation that you're promoting, that you would include that with us.
Okay.
So if it's one thing to have a general policy statement, it's another. And if that doesn't include the specifics, it's nice to have the specifics.
Okay.
Because often, like I said before, devil's in the details on these things.
Yeah, and often so many of them don't get developed until later in the year.
Right.
Or even into legislative session, but the ones I can get a hold of now,
But
I
the
certainly
ones that
will.
actually there's a specific request
Yeah.
for, it would be nice to have the details on that.
Sure.
Any other questions for Linda on these items? Okay.
Any initial input on what to leave on or take off, or?
Slightly different question. Just in understanding how you approach this beyond the substantive issues that you, on behalf of the district, are trying to advance, how do you do it? I mean, are you in Olympia? Do we have a lobbyist? Or how does that whole process work?
Combination. My role is to focus mainly on working with our local legislators. So it's the 15 from the regions that connect into Spokane County. I do go to Olympia on occasion. Most of my work is done more by emails and telephone. And then we do have a lobbyist with WASALFO, the Washington State Association of Local Public Health Officials. That is a principal job of theirs, is to be in Olympia full-time. Any other questions?
Additional questions? Okay, thank you. All right, Mike. Right? Oh.
Can I make a quick comment to
Yes.
Brian while Mike's walking up? So another thing that happens is they usually have a lobby day in Olympia for all the local public health officials and board members to come and weigh in. And so I'm sure we'll get a heads up about when that is, and board members can participate in that as well. So.
Mike.
Hi, thank you. Just a quick update from the finance world. First of all, I want to thank Mrs. Boyson and Councilmember Beggs for being on the Finance and Budget Committee the whole year. We've had a little bit of a revolving door going on as this year went along with people vacating and going. So if what I heard earlier was correct, it sounds like we might be in interest for the opportunity for Councilmember Munch and former Councilmember Hafner to be on this Budget and Finance Committee. Well, that opportunity starts today because our next Budget Finance Committee is immediately following this board meeting up in Torney's office. So I know it's short notice for two of you, but the reason today is very important is we always bring our budget to the board way before cities and counties do. And so we actually have a finalized version that our exec team have put forward that I'm bringing to the Budget and Finance Committee today for them to look through. And if they give the approval to move forward, that's what will be mailed out to the whole board in the next week. And with hopefully the passage of the budget for 2017 at the October meeting. So it is a very important meeting, and if you can attend, it'd be nice to have you there, and look forward to next month where we get to talk actual numbers about the budget. So, any questions?
Sorry. Any questions for Mike? Great, thank you. That brings us to our consent agenda. Do I have a motion to approve our consent agenda?
So moved.
I'll second.
I have a motion and a second to approve our consent agenda, which includes the meeting minutes from August 18th and the vouchers from August 1st through 31st, 2016. Any discussion on any of these items? Okay, seeing none, all in favor say aye.
Aye.
Aye. Opposed? Passes unanimously. All right, that brings us to item number 9, our report, influenza and vaccine update. Dorothy.
Mention it.
Hi there. I'm Dorothy McEachern. I'm an epidemiologist here. Have been for many years. I'm in that almost 20-year category. But I'm now working on a new project looking at infection prevention in healthcare facilities. Right now I'm focusing on long-term care in particular. So today I'm going to talk to you about something that jives really well with my current work, but is also a long-standing public health issue. Talking about
I'm sorry, can I just interrupt you really fast? Before she gets started, I do want to point out that item 10A is an action item that is going to be a result of her presentation. And we did send the information out to you ahead of time. I wanted you to listen with understanding that we are going to be asking you to make an action. And typically we don't. We typically do like to do a presentation and then have you vote on it the following month. But because of the timeliness of this issue, we are going to ask that you vote at the end of her presentation. So just please listen with that awareness so if you have questions. Thank you. I'm sorry.
Okay, sure. So I'm talking today about influenza, which is a yearly epidemic worldwide. This has been recognized for many centuries, hence the name. Influenza means influence of the stars. It's a seasonal affliction every year on every continent. Where is it? Oh, there it is. Okay. And I thank my colleague Mark Springer for some of these slides as I pulled this together pretty quickly. So I wanted to first start off giving a little information about influenza because oftentimes it's referred to as just the flu. It's not just the flu. It's a very different thing than something that's commonly confused with, which is a cold. So it's cold and flu season. They're two very distinct illnesses. Colds generally are mild with coughing, sneezing, sore throat. Influenza is quite a different illness with high fevers, exhaustion, muscle aches, usually a terrible cough. And a particularly concerning thing about influenza is how contagious it is, but also what a setup it is for a person to then develop pneumonia. Very different than a cold. Okay, so here's the transmission. It incubates usually in the body for 1 to 4 days, commonly right about 2. The reason, part of the reason that it's really hard to control is that you're communicable to others a day before you become sick. So you're incubating, you cough and sneeze, and someone else gets that, breathes in that virus. So we know that you're also communicable for about 5 days after your onset of symptoms. And children and immune-compromised persons, as per usual, those windows are open a little bit longer. So primarily, influenza is transmitted through respiratory droplets, like I said, sneezing, coughing, singing, and secondarily by touching surfaces that people have coughed on or sneezed on, or if there's goo on them and you touch that and then touch your eyes and nose. Usually we don't do that, but sometimes we do it without knowing. So we've got 2 main ways to prevent influenza, and that is vaccination. And that's recommended for everyone over 6 months. It took a long, long time for Centers for Disease Control and the Advisory Committee on Immunizations to come to this recommendation of everyone over 6 months of age. Every year they were, as I started out here, they were adding another age group, and first elderly were over 65, and then they were over 60, and then they were over 50, and then it became young people, and then young people up to 18, and now it's everybody. So that's a good thing. And our other great way to prevent transmission is respiratory etiquette. So covering your cough, sneezing into your sleeve, washing your hands, throwing your tissues away, and staying out of circulation when you're sick too. Okay, so in the U.S., usually 10 to 20% of our residents will get the flu in any given year. 220,000 people will be hospitalized. most of those will be people over 65. The death rate ranges wildly from year to year, anywhere from 3,300 to 48,000. And that's the span over the last 30 years. I'll tell you a little bit more about just H3N2 in a minute, but that generally affects older people. And so that affects them much more significantly. And so when we have an H3N2 season, we have, even more deaths in the elderly. So usually what you're hearing about is influenza A. It is the most likely to cause disease in humans and animals. So it has a quite a pandemic potential every year. Influenza B, we usually see some of every year. It doesn't change as much. So if there are epidemics, generally they're milder, and this is something that occurs only in humans. Influenza C, we rarely see at all. This little chart is just to show you about that H and N type. So that the H types, basically they're proteins on the virus that make it sticky. So the virus sticks to a cell. And the N types make it able to penetrate into that cell to make the other person become sick. So the little icons are just for the different animals that are most affected by these types. So there's our friend up on the top, H1N1, so animals or humans, pigs, and wildfowl. Those are big concerns for when we have avian influenza, when we have a type that's easily transmissible and virulent in humans. And you've probably heard a little bit about this also, drift and shift. So influenza viruses are changing all the time. They're really smart. They always want to be able to live just like we do. So they go into a person and, populate. And so so the first one, I don't know how well you can see it, but so a drift is where the virus itself changes a little bit. And so that means the vaccine that's targeted toward the original virus isn't going to work as well. It might provide some protection. But usually this is when we see that the vaccine isn't a good match for the circulating virus. A shift is something very different. So that virus turns into something completely unlike the original virus. So there isn't a vaccine that will cover that. So that's where we have a lot of potential for pandemics. So who's most at risk for flu complications? If you think of pretty much any health condition, I learned this acronym way back in undergrad, YOPI, so it's young, old, pregnant, and immune compromised. Those people are more susceptible to almost everything. Children are circulating closely, exchanging lots of goo that would make them sick. Old people just have weakened response even when they get a vaccine. They have they're more susceptible in general. Pregnant women, certainly we have found that in the last decade or so, the pregnant women are very susceptible to influenza, and the newborn is also very much at risk, and they can't get vaccinated. Immune-compromised people, again, this is something we're finding out more about in the last several years, so people with chronic conditions, and they're not just respiratory conditions, that's what's been interesting. Diabetes makes you more susceptible to flu complications. Obesity makes you more susceptible. A whole range of, heart conditions, they make you more susceptible to complications from the flu. So I just wanted to quickly tell you, influenza is not a reportable disease, and so how do we keep track of it with all these cases every year? We have lab reporting. And this is at sites throughout the United States. So a person gets a respiratory specimen. If it's positive for influenza, they're reported nationally. This is a graph of influenza-like illness. So this is a totally different thing where the person isn't necessarily tested. There are providers around the country that they pick every 10 persons, and they say this person came in for influenza-like illness. And just in case you didn't know what that was, it says, did the doctor say you have the flu? No. He said I had flu-like symptoms. And what does that mean? Well, it means if I have death-like symptoms, I'd be dead. So they have influenza-like illness. They're not tested necessarily, but they probably have influenza. In 122 cities across the U.S., the influenza and pneumonia mortality is reported. Spokane is one of those cities. And the reason why we put those together is that influenza often causes pneumonia or sets up an individual for pneumonia. And many times influenza is listed on the death certificate as a contributing cause, but pneumonia is what killed the person. A few years back, when we had 2009, when we had the influenza that really affected children, pediatric deaths became reportable nationwide. This is sorry, I forgot my glasses. Oh, these are in some cities, laboratory-confirmed influenza hospitalizations. And we have this in Spokane, too. So luckily for us, in 2009, our Board of Health decided to make this a reportable condition in Spokane. This is not true across Washington even. So we are able to keep tabs on what's happening to our population during flu season. As far as hospitalization, obviously the most highly affected individuals. And lastly, this is the map that comes out every week during flu season that says where flu is happening in the United States, just to have a broader view of what's happening nationwide. So this was toward the end of last flu season. There wasn't much activity. Okay, so now I'm going to move into this what we're proposing as far as the resolution. It turns out that a lot of the materials or the things that we think about with medical providers is first, do no harm, which is apparently a translation of a Latin thing from way back when, which is not really used anymore. This is called the modern Hippocratic Oath, which was written in 1964. And I'm not intending that you read that, but just to say that, so this is what physicians would maybe recite or read as they, get their medical licenses. Prominently, I will prevent disease whenever I can, for prevention is preferable to cure. And the other one I wanted to point out is this: I will respect the hard-won scientific gains. Okay, so now I wanted to talk about flu vaccination coverage among healthcare professionals. So what happens with this is that CDC conducts kind of an internet survey every season to see how many of the personnel are getting flu vaccine. So they do that early in the season and then later in the season. And just like everyone else, healthcare providers maybe wait and see what the season looks like before they decide to get serious to get their vaccines. So you see that there's a slight increase over time, but still, I'll give you the exact numbers here, but you could be seeing a health care provider, 1 out of 3 probably isn't vaccinated, or maybe 1 out of 4 if you're not lucky. So here's the overall numbers. So this means, 2 out of your 3 healthcare providers, maybe early in the season, are vaccinated, and about 3 out of 4 later on. But this is nowhere near the target for influenza vaccination. Luckily, in hospitals, people are a little more serious about getting flu vaccine. In long-term care, not so much. In long-term care where people reside, hospitals, they stay in briefly, but in long-term care, much of the staff is not vaccinated. But what seems to make a really big difference in either type of facility is whether their employer required the vaccine or not. In most places, I have found vaccine is offered and it's free. There's not a cost barrier at all. And even if there was, usually you can get a flu shot for $20. So you see this wide discrepancy over if it's required, up to 96% of people will get vaccinated. But if there's no recommendation, no policy, less than half. And here you can see what the uptake is among different practitioners. It's great, pharmacists believe in what they're giving out, so that's good. And then, medical staff around 80%, so it's not too bad, but we're still not at the 90%. The administrative and non-clinical support, the people you check in with at the hospital, they're only, maybe 60% of them. There are some other staff that were described in the CDC document. They were described as aides, so I wasn't exactly sure what their functions were, because they should be under other clinicians. So I left those out, but those were like way down in the 40s. Okay, so among unvaccinated healthcare personnel who did not intend to get the flu vaccination, and of course this is a voluntary survey that they do, the most common reason reported for not getting vaccinated was that they think vaccines don't work. The flu vaccine is what we've got, and it's some years it's not as effective as others, but it is what we have to protect our population. And the second most common reason was that they don't need the vaccine. Well, we would like to compare this to wearing seatbelts. Do you know when you need a seatbelt? Do you know which day you're going to get in a crash? No, you put your seatbelt on every time. A flu vaccine protects you every time. 10 to 20%. That's a much higher statistic than the 3,000 people that get in crashes every month in the United States. 10 to 20% of the population will get sick in any given year. And here's some other statistics about who dies from what. These are a little bit dated, but you can see that the flu and pneumonia kill considerable number of people each year. And this was, remember I told you there was quite a range, but this is almost 54,000 people who died from influenza and pneumonia in 2011. Nowhere, nothing else came near that. Skin cancer, drowning, HIV, automobile accidents. So what we're proposing with this resolution is that, and Linda will talk more about it, but that the Board of Health encourages healthcare facilities to mandate vaccination of their employees. They either take a vaccine or they wear a mask during the entire flu season, which is determined locally when we see a certain level of individuals coming into the emergency room for flu-like symptoms. So we make that decision in coordination with Sacred Heart. And they have instituted this policy at all the Providence facilities in Spokane. So all healthcare personnel must vaccinate or mask during the season. So we're not forcing people to get vaccinated if they have a medical contraindication or some other tightly held belief that they shouldn't get the vaccine, but they will have to wear a mask because their duty is there to protect their people, not make them sick, their clients. So I would say also that this policy has been adopted at Virginia Mason Hospital in Seattle. They have something like 98%. They went up from about 30 to 50% of their employees in any given year. And now we're up to 96%. Individuals need to sign a declination. There's all kinds of ways that they can be encouraged to take the vaccine, and that would be left for them to decide. But so with this resolution and with the support of all these very prestigious organizations, we're proposing that the board adopt this resolution to encourage facilities to mandate this practice. Since we can't mandate that, but they can do that within their own facilities, and that's what the purpose of the resolution is.
Great, thank you. Any questions? Yes.
Thanks, Dorothy. Do you have data on the percentage of people who get vaccinated and then get the flu?
I don't have it.
Is it even available?
I don't know that I've seen that. Usually what happens is if a person comes in with respiratory symptoms to the hospital, they will be vaccinated at that time if they haven't been. But, when I did a little study, it was really hard to parse out locally what had happened with, were they vaccinated within an appropriate time frame. So, because the vaccine takes about 2 weeks to be fully effective, and, I got the vaccine 2 days ago and now I have the flu. Did I get the flu? When did I get the flu? I got the flu, before I was incubating it when I got the shot. So I don't think there's really good information about that.
And then on masks, so my understanding is viruses are very small. And so would there be a requirement on the type of mask a person has to wear?
No.
In order to?
Okay. It's basically a surgical mask. There's two different kinds. There's an N95, which is a high-level mask, and a surgical mask, and we would just be requiring the surgical mask.
Okay, thank you.
Mm-hmm.
Other questions, Brian?
You mentioned that they're effective or less effective depending on the year. Could you just talk about what are those factors and how do they measure that and what does that look like?
So partly it's so all these vaccines pretty much are still made in eggs. So that means for the United States we need 200 million eggs to make that vaccines for the coming year. Some of them are changing now to being cell culture, but the vast majority is still made in eggs. So what happens is the vaccine, those H and N types, The scientists look and see what's circulating in the southern hemisphere as far as those H and N types, and a little bit more detail. But then they make the vaccine based on what was circulating. If it shifts or drifts during that period of time, it may not be as effective. And then, of course, there are people who it's not as effective in as, the elderly, for instance.
But in terms of, you mentioned that people are reluctant because they don't think it's effective.
Mm-hmm.
What are they judging that on? Is that just anecdotal, or is there evidence each year of, hey, this year it was a good match, it wasn't a good match, and what's the percentage?
Yes, every year that's evaluated, how effective it is based on, based on seeing what happens with people who get vaccinated or who don't get vaccinated. What we do know is that even when people get vaccinated and still get the flu, their illness is much less significant. But every year is kind of different. Chuck?
Dorothy?
Yes.
As I read this, it says all care facilities, all healthcare facilities.
Mm-hmm.
Just recently I had to take my wife to emergency, so that's a health facility. And then she went to a couple specialists, those are health facilities. And she ended up going out to another facility to double check this. One was physical therapy. Now, what's considered, I guess, the definition of health facility? Because I think of all those arenas that my wife visited, it would be very nice to know that they've either had their flu shot or a masking done. Because even though we've had our pneumonia shot, it would still be nice to know that all the prevention is possible for us. Because we're that elderly group,
right? Yeah,
and so we need to take care of ourselves very, very much in regards to that. So I guess that would be one of my questions.
So that would be all those facilities. That would be hospitals, urgent cares, long-term care, walk-in clinics.
Okay, so
that's what the proposal is. That it's all,
and even physical therapy, that type of thing. That's
if
all
they're providing some kind of health care, yes.
Mm-hmm.
And what this board is being asked to do is, we are not actually mandating them. We are asking that those facilities create policies that mandate their employees.
Yes.
Mm-hmm.
Right.
So we're asking them to step up. So, great. Questions for Dorothy or for Linda?
Just wanted to make a quick note that per the process that we have, we did take this to the policy committee and they strongly endorsed bringing it forward to the board. And as Shelley had mentioned early on, normally we really like to do a two-step process, but because of the timing with the flu season, the policy committee really wanted to see if the board would be comfortable taking a vote at this time. So.
Any questions? Go ahead.
So if the board were to approve the resolution today, what kind of next steps would happen? How would you be able to start contacting and letting folks know of our recommendation?
What we'll be doing is working with media as well as then doing direct outreach to the care facilities and in particular the long-term care facilities through Dorothy and her work with those specifically.
So,
go ahead.
Well, I'll make a motion that we approve resolution 16-05.
I'll second that.
I have a motion to adopt resolution 16-05, encouraging all healthcare facilities to adopt policies that mandate all staff to either receive annual influenza vaccine or wear a mask during the influenza season. Any further discussion or comments on this item? Okay, all those in favor of the motion say aye.
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 Opposed?
Me.
Okay, I have 1, 2, 3, 4, 5, 6 ayes and 1 nay.
2 nays.
Okay, so 5 ayes and 2 nays. Okay, thank you. That brings us down to item 10B on our agenda today, and this is so you guys have we've talked quite a bit about our process that we've been going through around the health officer and the administrator. We've had multiple conversations. We did send emails out to information in your packet. And I'm going to go ahead and did you want to talk about?
Oh, sure.
So you'll see what we're asking today is for a change to amend the bylaws to reflect the change in the governance structure so that the administrator is the head of the agency versus the health director. And I'm going to let Chuck talk about it as well.
If some of you are not available, have not been available, but as I was have been a member of an ad hoc committee of one, I guess you might say, but this had to do with evaluating the process that we've been using for the health district for, I think, the last 6 years. And that's where the health district officer would be reporting to the board directly, rather than the administrator. So in our study, we then double-checked and started calling the other health districts within the state to get a general idea of exactly what their process was, who was responsible to whom, and so forth. And if you recall, Keith made a report to this board, what was it, would be last board meeting, or the one before that? Nevertheless, as we made the telephone calls, we spent a lot of time talking to those particular administrators and or health district officers. And as we went through that, for instance, we talked to Whatcom County, Kitsap, Snohomish, Thurston, Clark County, Secretary of Health, and in regards to all of those that we spoke to and spent over a good time, like an hour and a half or more, it came down to the fact two things were pretty evident. That they felt that an administrator is trained in how to manage. That's how they spend their time. And a doctor is, again, as you well know, goes through specific training, very I guess might you say, very unique kind of training. And each and every one of these, except for one position, simply told us that in their recommendation that a doctor needs to do their job and what they're trained for, administrator needs to do their job. And they have found that it became more efficient for them to also do that, to have the administrator check to the board. Now, there's some exceptions. There was one particular county that they had both an administrator and a health officer. The administrator did check with to the board, but because of some financial concerns and restraints, they had to combine them. So they combined the both. And the health officer, in that case, reported to the board, but he also said to myself and to Keith that was not the ideal situation. He said it was almost for sure that he had a good administrative team that made it possible for him to do that. The other exception we found was that in one of the larger areas, that the health office district reported to the board, but he didn't have enough time to do the job administratively, so he spent more time administratively than he did on the health concerns, so they would go ahead and contract out of the system in order so they could take care of the health concerns. So I thought that was kind of ironic that here again, the other ones had simply stated before that the administrator. And then if you look in your packet, if you haven't already done so, I think there are approximately 32 of these health districts where the administrator reports to the board. There are 3 that do not, so we're talking about 65 in Snohomish, and that is one of the counties that I just mentioned because of financial constraints they had to combine. Spokane, that's us. And we've been doing this for the last 6 years, approximately the last 6 years. And then the other, Tacoma Pierce, of course, is the one I just mentioned, where the doctor there went back and got his MA in administration so that he could provide that service, and yet in many instances he had to contract out for another doctor. So my recommendation, and what Keith and I found out, and then going through what the committee had also done in regards to many of these other areas, it was simply our recommendation is that we would change the bylaws so the administrator for Spokane County would be the one responsible to this board.
So, Brian, you had asked for this information, so I wanted to make sure that we provided it for you. So the recommendation for the ad hoc selection committee for selecting the health officer, when we first started this process, we decided we needed to, before we were to go out and hire the health officer, decide what role that person should play going forward. And so it's after doing a ton of homework on this item, and I will fully admit that Chuck and Keith and others spent many, many hours on the phone calling other health districts to learn from their board members, their directors, and others. Our recommendation is that we change our bylaws to put the administrator in charge of the agency and to direct the agency, and that the health officer report to the administrator. Brian?
I was just going to, with all respect to all the work that you all did.
Thank you.
I really like the idea of the health officer reporting to the board, and part of it's informed over experience I had in Whatcom when I was there, where the health officer reported to the administrator, started raising public health issues, and then got fired because of politics and things like that. And so for me, I've always felt like that we can have an administrator that reports to the health officer and does the administrative work and let the medical person do. But there is something about the code of ethics that a medical doctor has that's just emblazoned in them through med school that I feel like I like that extra level of protection for public health, which is not a reflection on any current personnel or anything like that, but it's...
Well, Bryn, we discussed that quite openly with all the people that we talked with, and they felt that because of the mutual agreement and working relationship that the administrator had with the health officer, they came down where the health officer still has to make those kind of decisions that's best health-wise for the whole region. And they felt that turned out to many instances being the best solution, simply because for financial problems, concerns, continuity of who really reported to who, and I guess the delineation of the truth was the fact that the health officer still is responsible, even under the statutes, regarding the health concerns, but that was brought through the administrator. But each and every one of them, and even the one that I told you had to go out and contract with other medical doctors to fulfill his obligation, he felt that under the circumstances, an administrator with that kind of training is better for the overall picture working with a health officer. Now that's what we got. Right. You know, I'm only the messenger.
Right.
Okay, and so I can only report to what the positive reaction was when we asked them those particular questions. And I really felt that the response that we got was very valid. I don't think any of them were kidding or giving us a bad time and saying, oh no, because I'm under this particular system, that's why it's so good. I think when they pointed out exactly all the things that they were able to do under that system turned out to be very valuable for them. So that's why this group, the ad hoc group, came up and recommended that.
Can I just one quick follow-up? When the people you were talking to, were you talking to health officers and administrators, or both?
Yes.
Or what was the mix?
Mm-hmm. Both. Yeah.
Mm-hmm.
And just so you know, we wouldn't take off the health officer report off of the board agenda.
I understand that, and just to clarify, I'm not talking really just about the pure health officer kinds of things of like quarantine, no quarantine. Yeah. It's just that there's a lot of administrative decisions and budget and things like that impact public health that might look more administrative. So that's.
And the only other thing we came out with, looking on this chart that you received today in your packet, when you consider that we are one of the 32 that are still what some of the people said an antiquated system in order to move forward with regional health. And that's what we were told.
Amber.
So, Brian, what I'm hearing from you say, though, is not that... Are you saying that you're concerned about that there's not a direct relationship between the board and the health officer? Is that what?
Because you're going to have.
Sounds like I'm hearing that you agree that an administrator taking most of the management, role is appropriate.
Right.
Are there? I wish we had some of the other. I had some in my. Didn't bring my file with me, but in some of the other districts, they may have the health officer still direct to the board, but I don't know if that's the
Well,
case.
they do. The health officer reports to the board on medical concerns and what's happening there. So that there's not a void there.
But you're talking about the hiring and firing piece.
So there's not a void in that particular portion of it at all. So but it's the fact that the director or the administrator is one that's directly responsible for the total organization.
So and I haven't looked at the RCW, but can they both directly report to the board in terms of hire fire, or does you have to go one or the other?
It says the Board of Health shall approve the appointment of a health district officer.
It was the firing that I was.
The health district officer shall be a qualified physician trained and experienced. I'm guessing if an administrator fired the health officer without board approval, that he would or she would soon be following. Would be my guess.
I would think so too.
Yes.
My question, I have the same concerns that Councilmember Beggs does. My question is, did anybody question staff in this process? So was there any interview of the staff here?
Local staff?
Yes.
Yeah, actually, both didn't Kevin meet with, Kevin's not here, I wish Kevin was here because he chaired this committee. Kevin met with the staff.
And I think Kevin,
And Keith.
Okay, I'm looking at across, I'm seeing shaking of heads. Keith did.
Keith met with some of the executive leadership team.
Well, I'm not talking about the leadership team, I'm talking about staff going down.
I ultimately think that this is a decision of the board.
It is.
Right.
I'm asking if.
On how we want to
they've
set up the
been-
structure, yes.
Yes, it is. I'm asking if they've been questioned at all.
Yes, I do believe that, I don't think every single person in the health department was met with.
Just the layers of
But
staff.
Kevin and Keith, correct me if I'm wrong, but I believe Kevin and Keith.
More limited in terms of going down through staff. Certainly the discussion happened at the executive level, but I don't think that they went into depth at frontline staff as an example.
Other questions, comments? Okay, so the way this works is for our item on today's agenda, because it is a bylaw change, we do need 2/3 of the board present at today's meeting to approve it in order for it to be approved on the first touch. Otherwise, it goes to the board meeting next month. At which point does it take it takes 50
majority.
Then it's a majority vote on it. So just as an FYI, because it is a bylaws change in order to make this change. So any additional comments since you were on the committee as well?
Yeah, I'm on the committee, and I over the last couple weeks I was encouraging our chair to maybe put together kind of a briefing paper that would outline some of the reasons, and that, Mr. Hafner did outline them verbally, but he did call me today, and
Didn't that get sent?
no, he was rewriting it, and anyway, I think it would have been good to have a briefing paper. Personally, I'm in favor of the change, although I do wonder if we should clarify a little bit more about the role of the health officer. Maybe we don't need to do that in the legislative powers, duties, and functions, but it's kind of light. Maybe that just gets
Isn't that where it
discussed
comes out
in the
board-
job description.
The job description,
But-
because this is pretty big, I believe, on purpose in the bylaws and the job description.
I believe this is the administrative position description that you came up with prior to me coming back on this board. I think pretty well recognized with the responsibilities of the administrator and the health district officer, as I read it. So, well, in order to get the thing off the dime, I'll make a motion that we accept as what the recommendation is in the agenda.
Okay, I have a motion to approve item 10B, resolution 1606. Is there a second? I'll second.
I'll second for discussion.
Amber seconds for discussion. We have a motion and second. Discussion.
Can I ask, do people, just the feeling of people, it looks like in checking the RCW and looking in the bylaws that both could be appointed and fired by the board, but that they would simply have different responsibilities. They would have your health officer responsibilities, your administrative responsibilities. But I don't know if that was considered by the committee or not, or what people's thoughts are about that. Because I would feel better about that the health officer was reporting directly to the board.
So it was considered, and that's what Chuck talked about. We actually, when we started this conversation, it was, the reason we called so many different health districts around the state is because we were torn. We knew we wanted to, we all, I think, had a sense that we wanted to see, we were struggling with the whole health officer serving as administrator piece, that there was a challenge there. But what role should that play? And should they both report to the board? Should the health officer? But then, if you have them both report to the board, does that create internal conflicts? What were those challenges? We decided the best thing to do was to actually do our homework on it. So that's why we called and we had discussions with the Department of Health and the work that they do with the health districts. We had discussion with health directors. We had discussion with medical health officers. All of those conversations were had, and then we came back. We've had lots of discussions at our committee level. I wish Kevin was here too, because he put a ton of time and energy into this as well. So there really was a lot of homework put into it, and ultimately, after all the feedback we came back with, we decided that we could further define what each of those positions does under the job description, but that ultimately the board would play, as you can see, a role in the appointment of the health officer, but that health officer would report to the administrator. It just helps with clarifying that order.
I think we went in there with a very open mind trying to find out what best works for the health districts and asking for that type of information. And now even the Secretary of Health highly recommended that the administrator report to the board.
You mean that? Yeah.
And he works with all these health districts. So to me, when he made that particular statement and said, think about that, and he had a whole 2 pages of information for us, it kind of said, well, wow, wait a minute, why? Because of the efficiency, but they have the organization and so forth. They just simply said the management skills are important. Not taking away what the health officer does, because he'll still make reports to the board and so forth. But again, it came down to saying you have to have one boss. Now that's, and I'm just relating to you again. Don't kill the messenger. I'm a pretty nice guy.
So can I just make one comment too?
Yeah.
I could go either way, whether the board were to. I do want to see the change in the administrator. Kind of managing the overall day-to-day of the operation, and freeing up the health officer to be able to actually work on the public health issues, connect with other physicians in the community, and really be out there working, and even maybe statewide on issues. So what I want those two individuals to be very compatible and work well together. Mm-hmm. So however we can best accomplish that, the idea that we talked about was that if the administrator hires that individual, and then we have to approve that the hiring of that health officer, that then the administrator and health officer, hopefully they'll be looking for people that they can work well with together and be a joint kind of team. I don't know how maybe we can still accomplish that if the health officer is hired by the board and then works under the administrator, but that's just my goal. My goal is that those two individuals are really like a team, and they work well together, and there's a sense of they maybe find their best talents and strengths and work well, and maybe even change up their job descriptions a little bit down the road as they find out what each one is better at. So we heard that from several other health districts that their roles have evolved as, they found out where strengths were and such. So that's my goal. And I just want to be able to accomplish that. And if you have suggestions on changes where we could get to that, I just want those two individuals to be really a team that works well for our community.
What we didn't want to create by having two people report to the board is divisions within the staff where they felt like they could go to, the other person who could go to the board and, pitting them against each other. We really didn't want to create that kind of environment. And so we are just swapping these, but rather than having the health officer running the organization to the administrator running the organization, but the health officer, we can still be involved in that selection. As you can see, they'll still report out at the board, at every board meeting, their health officer report. So that's where we came from, is really trying to find that environment that would work well. And then based on having never been there as an organization and doing the homework, we felt like that really, we were all open-minded, I think, when we went into it. And that's just where it led us. So.
Well, I totally agree that there's going to be an administrator running the day-to-day, and it's really the question of who's the final reporting function, and maybe we lawyers sometimes do this of look for what's the worst possible thing that can happen, as opposed to
come on, set that hat aside today.
But I've seen it happen, so it's not just a theoretical. I've seen exactly what my fear is happen. And so my ideal is that that the board hires a health officer who then hires a really great administrator who does all the administration, but we have the public health filter from a doctor. But if that wasn't possible, then I would still want the hire-fire for a health officer with the board, so that minimizes the chance that some of those administrative efficiencies can overly impact the health issues. Because that's my worry, is that if the filter is through the administrator and the health officer has to fear for their job, they'll choose their battles, and we won't get that kind of robust public health perspective that we are so proud of the district that we have. And again, it's not individual people currently I'm worried about.
So would it make you feel more comfortable? Because it says the Board of Health shall approve the appointment of the health officer. Mm-hmm. So what if we were to say the appointment and, firing, however you want to say it, but that the health officer still reports to the administrator? So that ultimately the board would have to approve the firing. Would that help?
That would make it better, yeah.
Because we have to approve of the appointment. Like I said, I personally don't think that the administrator would fire the health officer without board approval. But if that would make you more comfortable, we can add a word in there. Shall.
Say it again, please.
So because it already says under number 3, the Board of Health shall approve the appointment of a health district officer. The district health officer shall be a qualified physician trained and experienced in public health. The health officer shall report to the administrator. We can add in there that they shall approve the appointment and
termination.
Because I honestly can't see an administrator getting rid of the health officer without board approval anyway, because if the board didn't agree with that, then the administrator's leaving.
It would embolden them to know that language is there, even though I agree with you.
I'm fine adding termination, appointment, termination. Yeah.
Question, do you want just termination or do you want discipline? What if it's something short of firing?
I guess I don't want to make it, I don't want to tie the hands too much you want the administrator to be able to run the organization, but
do we have
typically
anything
that
like
stuff comes before us?
Is there something in our handbook already about serious versus minor discipline? I don't know if we already make those gradations in our policies.
HR, we should have something.
Yeah, Sue might be able to speak to that more directly, but generally speaking, some of those handbook policies did not apply to whoever's the head of the agency because they're reporting directly to the board.
Yeah.
Correct.
So I think we could probably address the policy piece of it.
In the policies.
In the policies.
Yeah.
We can address that on the policy side. So do we need to, do we have to have a motion to amend? Or not really? I don't.
Well, we would, and now you're changing the bylaws, and those have to be given to folks 5 days in advance of
Even
the
by adding
meeting.
one word?
Well, it's a pretty substantive word.
I know.
Well, I'll make a motion to amend, and then we can argue with Michelle about whether or not we can pass it. But I will make a motion to amend to add the after appointment and termination. Those two words.
I have a motion to amend the item number 3, so that it says the Board of Health shall approve the appointment and termination. So adding the word termination. Is there a second?
Sure.
I have a motion and a second. Further discussion on that item? Okay, seeing none, all in favor of that motion, say aye.
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 Passes. Any nays?
Nay.
Okay, so any abstentions? Okay, so passes 1, 2, 4, 5, 2 nays, no, 1 nay, and 1 abstention. Okay, so now we're back to now we have an amended motion on the table. Okay, Brian, fight for us on this one. Now you can put your lawyer hat on.
I'm at a disadvantage because I don't know the rules.
But are you saying we have to wait till next month now because we amended the bylaws?
I mean, the proposed amendment is now something different than what was given to all of the board members. That by the bylaws has to be given to them 5 days in advance of any vote.
But it was provided to them.
But it looks different.
It's been amended,
Right.
but it was provided. The was provided.
Yeah, the original one was provided.
Yeah.
Are there any other changes then? So we should get them all out.
It's just, yeah, because it just pushes off our whole timeline. So are you telling us that we can't vote on this now?
I'm going to tell you that you can't vote on it now, under the way current bylaws are written.
All right.
Can I ask a question on another part of this? So you reference in here, Michelle, I know you helped write these changes with the input of the committee. Did, when you say in that Article 6, so page 4, the district health officer shall perform such duties as are provided by law, are we referencing just that RCW or anything else? I mean, it's just kind of any law that would be applicable to the health officer.
There is a specific RCW that sets forth what the health officer's duties are, so that's what I was referencing.
Okay, I mean, is that the one that's in parentheses underneath RCW 70.05.
I believe so, yes.
07, okay. Got it. So I mean, there's a lot more in that RCW then that we're just not we're just referencing it so we don't have to put it in here in full.
Correct.
Yeah, it's
Okay, but it's pretty well outlined what his or her duties are in Washington, per Washington state law.
Yeah, at least minimum duties.
And then we can add to that in the job description itself.
Correct.
Or we could add to it here, but you could also do it in the job description.
Correct.
Okay, so we don't have to put all the duties here. We can add more duties in the job description.
Why, sure.
Okay.
After it's determined. Yeah.
Okay.
So I do have a question. Where does this leave us now, Michelle?
So this will be continued until the October 27th board meeting.
Yeah, so we probably, for clarity, should then either table the vote or rescind it so it's not just hanging out there for the motion that was pending.
Oh, Mr. Hafner's motion in my second. So, so table or defer it to the next.
Continue it. Can't I just continue it?
Yes.
So I was continuing
Sure.
this
Let's
item.
do that.
Yeah.
So I'm going to continue item 10B, Resolution 1606, amending the Board of Health bylaws as amended to reflect a change in the governance structure to the administrator as the director of the agency. So we are going to continue the amended item to October 27th.
And that way, we'll meet the 5-day requirement, and all board members will receive the amended version.
Correct.
And then, so next meeting, then we will take a vote on which direction we're going to go.
Correct.
And does that have to, next meeting, is it just a majority vote now?
Yes, that would be that.
Okay.
Second reading.
Okay.
And it doesn't prevent us from taking action to move towards this goal at this point. It's just that we can't send out the notice until we do it. I mean, can we be writing the job description?
We've already written
No,
them.
it's already
They're
written?
already written. So
Okay.
they can be,
Can we just put those on the agenda for next month too then, for consideration?
we don't, the board, didn't we send them out for review and comment?
No. So a lot of these things that we talked about.
I thought they were going to be
happen.
sent out
Yeah,
for review
me
and
too.
comment. So, because I don't think the board technically, do we
Well, I
approve
would-
job descriptions in the sense of approving them as a resolution? I don't know if we do,
I
but
know, but I'd sure like to make sure we're on the right page with how we're dividing up the duties.
yeah. Okay. All right, so that item is continued until next month. We are running just a few minutes behind, so we need to get busy. We have an executive session for labor negotiations. We anticipate this will take 10 minutes, correct? Any action as a result of this executive session?
Sue, 10 minutes, you think?
Do you need less than that?
I think we could do it in 5.
Okay, so let's take, I was going to say, let's do 5 if we can. We'll continue if we need to. So we're going to go into executive session regarding labor negotiations, guidance pursuant to RCW 42.30.140. So if everyone who is not a member of the board or on the labor negotiations team can step out, we're going into executive session at, by the time everyone gets out of here, 1/4 after, we'll go in for 5 minutes. We're coming out of executive session. No action as a result of our executive session. It is board member check-in time. Amber?
I don't think I have anything.
I'll go this way. Mike?
Nothing to remark.
Nothing from you?
You guys are making this way too easy. Lori?
I'm good, thank you.
Chuck?
Thank you very much for having me back.
Welcome. We enjoy having you back. Great. I have nothing either. So our next regular Board of Health meeting is scheduled for October 27th, and we are adjourned. Have a great afternoon.